Hi, I'm Dr. Alexandra Filingeri, registered dietitian, doctor of clinical nutrition, and I'm sitting here with world-renowned plastic surgeon,
Dr. Thomas Romo, a plastic surgeon in New York City. I'm here to introduce you to our new podcast, We Got Your Number.
We are here to break down evidence-based information and real-world experience, and we're going to bring in some of the top experts in the world because
We got your number. How can we improve diabetes treatment in this country?
let's bring in experts and really talk about what supplements actually
Can
help.
we improve our sleep health by using these medications?
How much protein do people really need to
Can
eat?
nutrition solve all of our problems?
What happens if someone comes off their weight loss medications?
Welcome back to our podcast, We Got Your Number. Dr. Dina Peralta, a double board certified weight loss specialist and pediatrician, MD, and a good friend, and we've worked on many, many patients together. And we're going to do a little deeper dive because we were talking about the GLP-1s and the medications. Before there was GLP-1s, we've been talking about diabetes and obesity. It's funny, you know, if you go back to the days of Rubens, where you had these big round women in their paintings, which was considered beautiful. And then so it's very much a culturally driven process. And then it became a health process now today. But it's still, there's a tremendous amount of obesity and that causing diabetes. And that's one of the reasons why we need to take these medications and or consider them the treatment of these. And why is that?
Well, these medications initially were started for patients with diabetes. Then during this process, we realized that a lot of the patients struggling with type 2 diabetes also experience overweight or obesity, and they happen to be losing weight in a very safe and sustainable manner. So then the medications got, studied for the approval, the FDA approval for overweight and obesity. So obesity, it's a pandemic. It keeps increasing worldwide. And this is not only United States. We see countries that in the past did not have high index of obesity now struggling with it. So definitely things are changing. Things are changing in the way that we eat, the amount of processed stuff that we put into our bodies, changing with people becoming more sedentary. A lot of people spending a lot of times on desks in front of the computer. And I would say people spend a lot of time in their electronics, not only working, but, you have social media, you have iPads, you have TVs. So there's a combination of factors that are causing, I think, the increase of obesity in the world.
In a global level.
At a global level.
Yeah,
We're
yeah,
not talking about an individual, right? Because when we're talking about individual, we know it's a multifactorial disease.
Correct.
Because obesity is a disease. So we know that we're looking at genetics and we're looking at epigenetics. We are looking at lifestyle. We're talking about emotional health, family history, and their own personal history, right? We need to look at hormones. We need to look at metabolic health, at physical activity. So definitely a multifactorial disease. But globally, it's just increasing.
So it's increasing, and we know that as we're talking about lifespan and versus health span, where this obesity problem, as it's increasing, it's a healthcare problem. Now, if we limit it to just the United States, it's the commonest cause of diabetes is obesity, and there are tremendous healthcare costs that are worsened by this by this disease process. Diabetes causes tremendous all kinds of problems with the body, and if we could get this under control, and what helped us with that, and the magic was these medications, the semaglutides coming out and helping us drop that weight. But it's going to be more than that because it's still all across the country and all across the globe. How are we going to get a hold of that?
So that's a great question. Because to have access, right, to GLP-1s, because they're expensive medications. And then when we look at diabetes, okay, fine, you have the ones that are indicated for diabetes, some insurance cover it. But when we are looking at the patient that has overweight or has obesity and comorbidities that don't have weight loss coverage, then this becomes very difficult because not everybody can afford to pay out of pocket for this type of medications, even though that they're trying to bring down the prices, but still significant high for somebody just to be paying for it monthly. Because when we're looking at obesity, it's a chronic disease. So it's not just like a quick fix, something that you're going to take for a couple of months. These are medications that need to be taken for a long period of time.
So let's get into that. So, the myth, and I always bring that up as the myth, and then everybody goes, no, 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 it's the truth. And I'm going like, the statement is everybody is happy that we found a medication that causes you to lose weight. But when you get off of them, you gain the weight back. Is that true? Is that a myth, or is that that's because they haven't modified the things that they need to modify?
Of course. I mean, it's a truth. I mean, because the medication, first, is not a magic fix. Like we keep saying, it has to be accompanied with lifestyle modifications, right? So if you have struggled with weight your whole life and you have made the changes in eating, physical activity, and all of that, and nothing has really make a significant impact, and now you're on GLP-1s and you're experiencing a significant amount of fat mass loss, weight loss, but ideally fat mass.
Correct.
Then if you stop the medication cold turkey, most likely you're going to gain the weight back. And if you stop the medication and you definitely didn't make any changes on your lifestyle, you're 100%, 200% getting that weight back.
Well, as a physician, so the thing is, I mean, we're still in the euphoria stage. In fact, because there was an inability to supply the amount of medication that people wanted, that's where the compounding issue came in.
Yeah.
People started compounding it, and talking about telehealth. I wrote an academic paper on telehealth. Telehealth is important, but two components. One, we're still in the euphoric phase, so everyone's talking about the medication, how you get the medication. No one's talking about what happens when you stop the medication. And the other are telehealth is wonderful, but at the same time, like any medication, this is a medication that you have to be, you have to have a prescription. So you have to be an MD or a nurse practitioner to get it. Therefore, there are complications just by taking the medication. I mean, nausea and vomiting and all those things, but there are more complicated cholecystitis and pancreatitis and major problems that can do this. And so if your physician is not someone you're getting this from, but it's a telehealth person.
Or a Medispa.
Or a Medispa, or any, exactly right, so I'm going to let you grab those two things about the telehealth and let you go a little deeper dive maybe on that, and also about the crescendo, decrescendo, going up and down. Everyone's talking about how can you get this medication, even going into compounding, but the process is, one day, I mean, because remember, there's a lot of financial incentive on this.
Yes.
Okay, they're selling medicines. They're so bad it's under the table. You can get it any way you can. But eventually, like any medication, if you were taking blood pressure medication, you'd want the patient eventually to get into a position where they don't have to take the medicine. And that's where that's going to be, how do we get there?
Well, ideally, but it all comes down to what is the cause of obesity, right? Like I said, if somebody is struggling with obesity their whole life, if somebody has genetic causes of obesity, we really have to identify what is the reason, because otherwise there's cases that the medication is designed for chronic use, that that you're not going to stop the medication. Because when you have a patient with hypertension and you put them on their medication and suddenly their blood pressure is perfect, you don't stop the medication because the blood pressure is perfect. If the patient didn't manage to lose the weight, to start physical activity, to eat correctly, odds are that you stop the medication and the patient is going to get the hypertension back. So the same thing goes for obesity. It is very important to put it into perspective that not all patients are the same. So when we talk about weight loss with GLP-1s, there is the approach of the right medication, how to start increasing the dose of the medication while maintaining good body composition. Because obviously we don't want rapid weight loss, because if we have rapid weight loss, what we're doing is we're losing a lot of muscle mass in the process. So we want healthy weight loss. And this is achieved by 1 to 2 pounds per week and monitoring body composition, eating the right amount of nutrients that your body needs to be able to maintain muscle mass, getting the right antioxidants in your body, the right amount of fibers, fats, carbs, everything. It's not just weight loss. So then the way I, carry my patients is we achieve healthy metabolic weight, because it's not weight per se. It's when we talk about metabolic health, then I switch my patients from weight loss phase to weight maintenance phase.
Great concept.
Yes, because it's not just stopping the medication, because it's not fair for your body. Your body now is used to this effect of satiety, decreased appetite, a slow gastric emptying, and let's not even talk about the amygdala and your cravings and your reward systems and the I want. So your body's used to this. So to stop your body cold turkey, it's really unfair to expect your body to just maintain the weight just like that. So we wean. So I start either decreasing the dose or weaning, spacing out the time that the patient it's getting the medication. Because if we're not trying to achieve weight loss, then we could play with the numbers. That's why it's very individual. It's not just, you go up, and then you stay in that dose, because every patient is different. You have patients that respond phenomenal to low doses of GLP-1s, and you have the patients that we have to increase until their maximum dose. And sometimes we have to use other medications together with GLP-1s to be able to, get the optimum result.
So that brings up two things. First of all, I like, as an MD to an MD, I like the statement that you make that these are our patients.
Yes.
Okay, they're not our clients.
Oh, no.
They're not our customers.
Mm-hmm.
They're actually our patients, and I treat patients, and you treat patients, and that requires the physicality of actually being together and seeing them and being their physician. Mm-hmm. So I like the
and
way,
taking responsibility
and
also
taking
for their care.
For their care. So I think that's a critical component to get out of this. I want you to kind of speak a little bit about microdosing, and what your thought process is on microdosing.
Microdosing, very controversial.
That's why I brought it up.
So it's, there's so much new research coming on the benefits of GLP-1s that, when we look at it, you don't really need to be overweight or struggling with obesity to be on a GLP-1. Because if you want the benefits, the anti-inflammatory benefits, the metabolic benefits, but it's important to know why you're taking the medication, right? Because if you have a person that says, I would like to microdose, or you the physician's I'm going to microdose you. So what's your starting point? Because most of the time when I'm going to start a patient on this medication, there is a reason, right? If I do a body composition analysis and I see that this person, the weight looks fine, the BMI, which I hate BMIs, but still we use BMIs.
Correct.
It falls on the right category. But when you see that person has an elevated fat mass, visceral fat is high, then, those things put things into perspective. And then why am I going to microdose that patient? I am going to start it in the lowest dose of the medication, depending on which medication is it. And that is not called microdosing. The concept of microdosing that people start thinking, if I'm in the lowest dose, I'm microdosing. You're not microdosing in the lowest dose. You are taking the medication.
Correct.
So we have to understand exactly what's the reason that you want to be on GLP-1s.
Well, the terminology.
Exactly.
Yeah.
So the concept like I'm just like in a 2.5 of tirzepatide, or I'm in a 0.25 of semaglutide. That is not microdosing.
But is there a microdosing technique?
There are microdosing techniques, and so what I normally would say, okay, if you're in a 2.5 and we do not need to lose weight and we just want specific effects of the GLP-1, we could do a 2.5 every 2 weeks, every 3 weeks. You could play around with it, but there are different techniques for microdosing, especially with the vials of tirzepatide or counting clicks with the pens for semaglutide. So there are ways, no? And also, if you have a patient that needs the medication and it's not tolerating the lowest dose, we could always use microdosing dose. So there has to be a reason.
And the thing is, again, because this medication is so new, and the facts and the medical based facts about what the benefits are still developing all the time. You talk about this in combination with hormone replacement therapy in menopausal women, but we're looking at it with improvements in Alzheimer's,
Yeah.
stroke, cardiovascular disease, sleep apnea.
Fatty liver.
It reminds me a lot when I hear the stories about when penicillin first came out, and it came out, it was the silver bullet. It was
Yeah.
going to cure everything until, and it cleared out the wards because people were getting healed. And then like anything else, it'll come and balance itself out about what are the positives and negatives. But it is really a wonder drug, but it is a drug, and they are our patients. So that's
They are our
one.
patients, and we owe our patients to be responsible, to educate them on how to take this medication to prevent side effects so they could have the best results possible.
Exactly. Now, as a plastic surgeon, I got to bring up one other aspect, obviously, because I'm working on patients and doing surgery, which is only one modality. I know that very much, but it's one modality of treating what we call the aging face. Okay, you get to a certain age and you develop what's academically, because we approach everything pretty much through an academic lens, because we're publishing and running FDA trials. So you get old enough, you develop the aging back, the aging knee, the aging heart.
Oh my God, you're killing me
and-
slowly,
and
man.
we actually call this the aging face. So, I mean, and it's a process, and it consists basically of two processes that occur as we age. One is volume loss. And so the volume in the face is fat, muscle, and bone. And then there's also gravity that's pulling down constantly, which is called ptosis, or it's a totic, spelled with a P, Tosis. It's a totic process. So you got that process going on. Since I'm married to a woman, I have a lot of women patients that are in my practice, plastic surgery practice. And I see that one of the problems that occur with the aging face, which it gets exacerbated, is menopause. So menopause even increases that loss of volume to the face. And then you bring in a GLP-1 on either side of that process. How am I supposed to manage that?
Oh, it's tricky. So you're getting a lot of business during the Ozempic era.
Well, it's called the Ozempic face.
Oh, yes.
So,
So, again, that comes down to who's prescribing it. Because one of the things I take pride of my patients is body composition. We know that when you have excessive fat loss, like you said, with age, we're losing collagen also in our body. And then if you're not eating enough protein, you're going to have muscle loss too. And this is why it's so important if you have a menopausal or perimenopausal woman, that they are placed on Ozempic or Zepbound, Mounjaro, Wegovy, you name it, all of the GLP-1s, that they are being followed correctly to prevent that muscle loss that reflects in the face, in the butt, anywhere. And not only that, bone. because these are the same women that will develop osteoporosis. And we know that muscle is key also for bone health. So, nutrition, super important. You have to be eating the right amount of protein to prevent muscle loss, resistance exercise, and being monitored by the right physician. Because when you see that excessive muscle loss, you know that patient is not being monitored correctly.
Well, and then that again, that leads on to that, and as an aesthetic plastic surgeon as well, we end up seeing eventually there is that loss, and then there's that ptosis, and that's where we come in surgically intervention wise, and it's all about natural today, natural beauty, natural as much as you can,
Like me.
right? And surgical intervention. Last topic I want to talk about, because I know this is your field, is talking about new medications that are coming out. So there are two. One is the triple Gs, which is the GLP-1, GIP, glucagon medications, and two will be the oral medications. So where do we kind of stand with that right now?
Well, we're very hopeful, right? They're in phase 3, so it's exciting. They show promises, and especially if these medications are going to be able to achieve more weight loss. But the most important part is that they should be able to maintain muscle. Okay, so we're very hopeful. I mean, there's so much going on in the pipeline. I think this is just the beginning, and I can't wait to see what the future holds, because if you ask me, this is one of the best things that has happened to medicine recently.
And I concur. I agree with you. It's very exciting. You don't want to get into the euphoria, but just we talk about healthcare as you and I as physicians and long-term friends managing patients. The healthcare costs in this country are just, we pump money into the healthcare, and yet people aren't getting healthier.
Because we pump money into treating disease.
Correct.
We don't pump money into preventing disease.
And one of the best ways of doing that is by losing weight.
Yes.
And losing weight and keeping your muscle mass is going to
I would say healthy weight.
healthy weight.
Healthy weight.
And it's going to have a tremendous impact. And all I was saying is, we don't want to get we always want to be part of the euphoria and cheerleading this at the same time maintaining our intellectual balance on this is a medicine, and there's going to be because there are complications with any medicine, and there's long term that you're going to be on this, that we are aware that these are our patients and they're going to need personal treatment.
Absolutely.
Dr. Peralta, we really want to thank you for being here today, and we want to make sure that we can have your contact information and social media information, so that if patients want to, and our viewers want to contact you, they can.
Oh, yeah, thank you. So they could find me on my website, New York Weight Wellness Medicine. Instagram is Dr. Dina Peralta. And in Facebook, New York Weight Wellness Medicine. And, in the Upper East Side, next to the Guggenheim.
We know there. We've been there. It's a lovely, wonderful place. Thank you for being here, Dina.
Thank you.